So thanks for inviting me to speak to you. It's been we had a nice dinner last night, and I hope that we'll have a lot of collaborative efforts forming in the next few years to help give some of the answers I suspect that I'll be saying I don't know to as you ask after I finish this talk. This is my email if you have any specific questions about things in the future, now or in the future I should say. This is what I was confronted with at 7 a.m. this morning. So this is I was going to switch minivans with Hal last night, but he didn't want to give me his, so probably a good thing. Nothing a chainsaw couldn't take care of, but I'll be in the market for a new car. So anyways, this is all things that, as we say at Hopkins, the man behind the curtain, Dr. Dietz, knows a lot more about these things than I do. But one of the things we do know is that arterial tortuosity and aneurysm is one of the things we see in Loeys-Dietz syndrome, and it doesn't necessarily have to be related to the blood vessels that are close to the heart, which is quite typical of Marfan syndrome, as you all know. We see more aneurysms in different locations, and one of the things I did a few years ago was I went and looked at the time we had 68 patients and went through all of the CT scans and clinical evaluations and looked at really what the outcomes were with non-cardioaortic, that essentially means non-aortic root aneurysm surgery. And that's essentially what I do, just to educate the difference between cardiac surgeons and vascular surgeons. So the training, we all go through the same training paradigms, but for vascular surgery we focus on what we call the periphery, that is all of the blood vessels outside of the heart. The heart surgeons will work near the heart, the aortic root, and that's essentially the difference. In fact, particularly at most of the centers you're all aware of, we all work sort of in unison as a team anyway, but if you see a vascular surgeon, chances are they're probably a little bit different than perhaps a heart surgeon that you've run into before, and they might have some biases that you'll have to sort of adjudicate or bounce off other people like myself or Dr. Dietz or Dr. Loeys. So this was just what we had looked at the time. You know, most of our patients were pretty young. The majority of them were between 8 and 30 years old, and this was sort of the classic LDS manifestations. 95% of the patients had a root aneurysm, and the bifid uvulas, hypertelorism, all of that was fairly typical of the population. And what we saw was a lot of people had carotid and vertebral tortuosity. It looks a little bit like this on the CAT scans. So when you have a CAT scan performed, the first thing the CT scan does is it runs sort of slicing down through the body, and then depending on your radiologist and the local technology, they can then create these sort of three-dimensional pictures. The pictures themselves are obviously very interesting, but in terms of the degree of tortuosity, that might be relevant to what we would think about how people could respond to surgery, or the implications of the tortuosity for the long run in terms of other vascular events. I think those are questions that we're hoping to answer as we get more clinical material and radiologic studies to look at. Not only did a lot of our patients have aortic root aneurysms, but a fair number of them had aneurysms of the descending thoracic aorta. So the descending thoracic aorta is the aorta that starts essentially past the artery that supplies the left arm and the left shoulder. So that artery is called the left vertebral artery, left subclavian artery right there, and so this is a descending thoracic aorta. This is the diaphragm, so the muscular bellows that allow you to breathe in and out, and then when you get down in the abdominal aorta, this is the blood vessel out to the liver, that one goes out to the spleen, that goes out to the intestine, and these are the two kidney arteries. Now this is where you get down to your legs. So that's a quick primer on anatomy, because in Loeys-Dietz syndrome we do see a number of patients with abdominal aortic aneurysms or tortuosity, that is the blood vessel themselves does a lot of twists and turns. This is a little bit how it looks in one of our patients, where you can see here's the two kidney arteries coming right here, and that's the abdominal aorta sort of bowing out to the side. The normal passage of the aorta coming down from the left subclavian is really right along the spine, so right in the middle, and then straight all the way down until it splits to supply each of the legs down here. So you can see a little bit of scoliosis in this area, but obviously the bending of the aorta is far in excess of the twisting of the spine. And at least in our series, and of course this is something that's perhaps biased, a lot of patients who would be sent to be evaluated at Hopkins have probably already had at least one surgery performed, but at least for a significant portion of patients, having several operations was required. You can see this is the first operation is usually, of course, the aortic root, but then there also are need for subsequent operations down the road for individual patients. And we have to pick these patients up and follow them closely because we don't want to lose the opportunity to fix patients when we have the available operations. So one of the things that I get asked a lot about, not only from groups such as yourself, but also just other physicians, is what about using stents to fix a lot of these aneurysms and the problems of the descending aorta? And the problem is that when you go back and you look at how these devices ran through the government and the FDA, having a connective tissue disorder was actually an exclusion criteria. So if you had a connective tissue disorder, you weren't allowed to be in one of the initial trials that allowed approval of these devices. And the concern was that the devices exert radial force. And there's also, of course, the tendency of the devices to straighten. So these devices look like essentially like the Chinese finger traps with fabric on top of them. They're not meant to take turns, so when you have the arch of the aorta here, which is a relatively tight turn, you can wind up with a problem here, which is that the greater curve of the aorta has been torn by the device's tendency to want to straighten against the curvature of the aorta. Some of the devices actually have bare metal stents, so they look almost like a picket fence without sort of a center to them, but this wire mesh can actually perforate the aorta. So this is a young patient I've been following with a little bit of the wire is actually outside of the aorta entirely. And then there's also just the concern regarding the fragility of the aortic wall. Could the stent graft actually traumatize the wall directly, so create a problem on the healthy aorta that it's sitting inside? Could it open up a new aortic tear in doing so, an issue we call a retrograde dissection? So instead of the type B dissection, which runs down through the chest into the abdomen, you can actually open a tear back towards the ascending aorta. And then, of course, what about the rest of the aorta? You can only put these stents in pieces of blood vessel that don't have any branches. So when you get to the abdominal aorta, where you have all those branches to the spleen and the liver and the intestines, you can't put a stent in there because the stent will run right across all of those critical branches. And if you don't have blood flow to your kidneys because a stent is run through there, well, then you're going to go on dialysis. So you can only use them on really the aorta in the chest because that's a straight tube. There's no critical branches that need to be preserved. So this is a picture of what this sort of looks like in a patient. This was a stent that was put in. This was published in literature. You can see right on the edge of the stent a tear has occurred running back down towards the heart. We do see problems with tears in these procedures in patients in their 60s and 70s with aneurysms. But when a stent graft causes a dissection, it's a real big problem. It's hard because the patients are under anesthesia already. It's usually emergency surgery, and the outcomes are not super. And interestingly, in this very large series of close to 1,000 patients, even though the Marfan group was only 1% of the total patients, they accounted for 12% of all of these new aortic tears that occurred after the procedure. And their line directly from the paper was that the retrograde type A dissection was the most common complication in Marfan patients after stent graft therapy. So of course this is not specific to Loeys-Dietz, but I think a general theme that runs through connective tissue disorders, that we have to be very careful with how stent grafts are applied to the Loeys-Dietz syndrome for fear of all of these sort of things I just mentioned. And then the other is that you can treat the aorta in the chest, but the problem is the aorta beyond in the abdomen can continue to develop, and indeed in this very short series of patients, 50% of them continue to develop aneurysms beyond the stent themselves. Same thing here. The aorta beyond the stent continued to dilate at a pretty rapid rate. 7 millimeters a year is a pretty big growth rate. It's actually about twice what the average growth rate is of a patient without a connective tissue disorder who has a thoracic aneurysm. And this was a series from University of Florida at Tallahassee, and and they had a lot of patients requiring conversion. Anyone who required a second stent to be placed all progressed to require subsequent surgery. So I think if I had to be asked about where stents can fit in connective tissue disorders, whether it's Marfan or Loeys-Dietz, I think it's okay in the short term, but really the device issues are a big problem for us in the long term. So there's a potential advantage for stents in an emergency, so a type B dissection that develops running down from the chest into the abdomen with concern for aortic rupture. Well, a stent is far better than waiting for a plane ride to a place with really good aortic surgeons. But you got to get to those places eventually, because virtually guaranteed, based upon all these other series I showed you, the stents aren't going to be the end-all of the story on the aorta. So I think that one of my conclusions about it is, obviously this is an aggressive aneurysm syndrome. It's clearly evident that we can diagnose this at the bedside in most patients, and you know, identifying patients with Loeys-Dietz is really key, because there's often a lot of confusion. Could this be something called vascular Ehlers-Danlos syndrome, which has also a very early presentation of vascular problems? But we know that the Loeys-Dietz group does very well with surgery, but the vascular EDS group does not. So we're doing well with surgery. I think we could probably offer more. We don't know exactly what the threshold is to consider moving forward with repair of aneurysms in some territories, but the growth rate is the key. So having proper imaging and seeing if different territories are growing rapidly is extremely important. And then, like I said, the stent graft repair of the aorta probably has a pretty limited role right now, and is probably not defined at all for elective situations. In emergencies, I think it's probably a reasonable option for most places. So a few words, but mostly wanted to open it up to questions if you have any.